Good morning. How are you? Good? Anxious for spring break? Probably. I wish we didn't have it. I just don't. You all are a well-oiled machine, and then you're going to come back all mushy-brained.
Is that next week?
Yes, it is. Today we're going to talk about acid-base balance. This is not a chemistry course. This acid-base discussion is tailored more directly to clinical practice and the acid-base disorders that you will likely encounter with your future patients. Even if you're not going into nursing, you might still be working with someone who has an acid-base problem. And if they do have that problem, I'm going to show you towards the end of this lecture that they might not act themselves. They might not be behaving in a logical way. And you cannot just slap them across the face and say, get out of it. So it doesn't matter if you're nursing or PT, OT, physical therapy, still be mindful of some of these issues, these presentations that a person with an acid-base imbalance may have. This equation is your responsibility. That is your responsibility. And a large part of today, we are going to be practicing how we use this calculation in our calculators. Depending on the make and model you have, it will dictate the order in which you enter things into your calculator. That's what I want to work with. If you don't have your calculator today, best make sure you bring it with you on Monday so we can figure out how your calculator wants the data inputted. Okay? Okay. So first of all, what you're seeing at the top, or I should say in the middle, is this reversible chemistry reaction. We know it's reversible because we see the double arrows. And that means it can swing from one side to the next. And we're going to talk about some principles of chemistry, but don't worry, we're going to turn it into principles in physiology that we know are tried and true, and they mirror each other. This is showing you that hydrogen ions, very acidic, can combine with bicarbonate, an anion. We think of that as a base. And then they combine to form carbonic acid, H2CO3. That can dissociate into water and CO2. Similarly, water and CO2 can combine to form carbonic acid, which can dissociate into bicarbonate and the hydrogen ion, or I should say carbonate. This equation, the pH equation, it's not your typical pH equation that you might have used for pH in your general chemistry. And we'll go over that. But this is what we need to use when we're playing with acids and bases. It is a modified pH equation. Now, again, when you're working in a clinical setting, no one is going to ask you to calculate the patient's pH. I want you to know how to calculate the patient's pH. I want you to know how you can interpret the issues and find out the etiology. Just like we learned in Unit 1 with the anemias. You can't just give someone a vitamin B12 shot if they have iron deficiency. That's not going to solve the issue. Let the treatment fit the diagnosis. And I hope by now that you appreciate that. I hope you appreciate the approach. So often I deal with ex-military, especially the medics, and they are so used to just being told this is what you do if this is what you do if this, but they're never really told why. There really isn't enough time to tell them why. It's train them, send them out, try and bring the soldiers back alive. I have I have experienced many people who are in a clinical setting or ex-military medics, whatever, come up to me and say, now I know why that works. And it makes so much more sense. I know why. And if you can know down to that level why, then nothing is going to faze you. Nothing. You're going to be very well prepared for your professional school. Don't let anyone rattle your cage. And we're going to have another talk another time of how you bite your tongue, especially when you're in your professional school. Because if you say, I think you're making a mistake, professor, you might be listed as insubordinate. So you got to be careful. Talk to them in private. And I've had that happen. Not to me, but to my students. So pH equals pKa, and I'll explain what that is, plus the log of bicarbonate levels over the levels of CO2, which are given in partial pressure. I will also explain to you why we have to have this correction factor of 0.03. And then I also will explain to you the orders of operation. Do you remember your orders of operation? Please excuse my dear Aunt Sally, or PEMDAS, as you probably, please excuse my dear Aunt Sally is a rhyme that we can use. P is for parentheses, E for exponents 2. Multiplication and division, addition and subtraction. If we follow all the rules, it will get us out of school. Sister Mary Beth Muir made us sing that every day after we said a decade of the rosary before we started math class. Every day. So orders of operation, we have to remember that as we practice today. Good morning.
Morning.
This is your traditional pH scale. And the traditional starting pH equation is pH is the negative log of the hydrogen ion concentration. Or another way of saying that is the log of 1 over the hydrogen ion concentration. So I don't want you to worry about the pH scale, except that you should know that it's inversely related. If hydrogen ion concentrations go up in a solution, the pH goes down. It's very acidic. If the hydrogen ion concentrations go down, if they're very low, then that means the pH goes up. It's very basic. So up there, we have a high concentration. Down here, we're getting progressively lower. And of course, neutral is 7.0. A typical amount of hydrogen ions, just to use that original equation, is 4 times 10 to the negative 8. You will not be responsible for this math. This is just me breaking it down for you using the distributive properties of math. So we know pH is the negative log of the hydrogen ion concentration. Substitute that for the number that you're given. Then distribute the negative log to both of these values. Negative log of 4 plus the negative log of 10 to the minus 8. Distribute negative log again to factors when multiplied that can give you 4, like 2 times 2. So if I had the negative log of 2 plus the negative log of 2 plus the negative log of 10 to the minus 8. And by the way, when you take the log of base 10, all you have to do is take that superscripted number, bring it down to its official place at the adult table at Thanksgiving dinner. The negative of a negative is what? Good. Now the negative log of 2 is 0.3. Please don't confuse that with the equation I showed you on the first slide, where that correction value is 0.03. This is just demonstration. So if I have the negative log of 2, negative log of 2, and they're both negative 0.3, that would be a negative 0.6. Take that away from 8, and we get our typical body pH, 7.40. For testing purposes, I want us to hold a very strict line for testing purposes to 7.40. I will explain why when we start getting into our examples. The truth is, our pH range in our body has an acceptable range of 7.35 to 7.45. And the viable range is even larger than that. Let me show you. So if the normal values of hydrogen are 4 times 10 to the negative 8, if we doubled that, doubled the hydrogen ion concentration, that means the pH is going to drop. Using that equation, we would get about 7.1. If it is cut in half, now we have 2 times 10 to the negative 8, and the pH would climb to 7.7. That is roughly our viable range. It's not exact, but I like to remember it that way because it's, if I double or half it, it's pretty much spot on. This picture shows you that it might be a little bit more extreme than what I'm showing you. That's fine, but for me, I like to remember it's roughly a doubling or halving, like cut in half, the hydrogen ion concentration. Even though that's viable range, I'm here to tell you, at those ranges, those extreme ranges, your patient is not doing well. They are very sick, and they need medical intervention. Again, accepted normal range is 7.35 to 7.45. But for testing purposes, what am I sticking to hard? 7.40. So students oftentimes ask, well, where are these acids coming from? They come from normal metabolic processes. They come from our Krebs cycle. They come from glycolysis, when you can't have the pyruvate go into the Krebs cycle, then it becomes lactic acid. We also generate from protein digestion ketone bodies like beta hydroxybutyrate, acetoacetic acid, and acetone. Many places, I guess I'm trying to say to you, we generate acids. So it's not just one place, and CO2, even though it doesn't look like it, is also an acid. Now I know you're probably thinking, Kara, wait a minute, the definition of an acid is something that can dissociate a hydrogen ion. And the definition of a base is something that can associate with hydrogen ions, take it out, free hydrogen from the solution. That's true. You're absolutely right. But I'll remind you to please look at that first slide and the reversible reaction. And if you look at that, you'll see CO2 plus water can form carbonic acid, which dissociates into carbonate and a hydrogen ion. So it might not directly be an acid, but it is certainly indirectly, and we're going to treat it as such. We know that pH changes, even small ones, can have drastic effects on cells and the way that your organ systems work. We know that. There's a reason why we collect blood almost immediately if someone is going to be admitted. We got to see what that starting panel looks like. Let me just kind of talk through something. If a cell inherently makes acids like I just showed you, we need to buffer them. A buffer is some sort of solution, some sort of chemical that can moderate pH adjustments, making them less extreme. Less extreme. Sort of like when I give you practice exams during my oh no moments. I'm trying to moderate. I'm trying to make sure your testing experience is less extreme. That's what I'm doing. I'm your buffer. Thank you, Kara.
Mm-hmm.
There are many different types of buffer in your body. One is a phosphate buffer. That is mostly used in the nephron itself. We won't really be talking too much about phosphate buffers for modulating, modifying pH of the filtrate in the nephron. We're going to cover some things, but not the phosphate system. The kidneys also, in the tubules, they have the ability of using ammonia for binding to hydrogen ions and forming ammonium. We won't really be talking about that pathway too much today either. They are good pathways to know, and I really hope that maybe someday the school offers you a pathophysiology class where you can learn more about those in better detail. Then we have proteins. Proteins are the most important intracellular and plasma buffers. They're very abundant, very abundant. Proteins are made inside the cells. Albumin is found in plasma at 7 grams %, and that's not even including all of the other immunoglobulins that we find there, all of the other proteins we find there. And the reason why proteins are really good as a buffer is because if they have a good amount of histidine residues, histidine, because of this ring, this imidazole ring, it can bind, nitrogens can bind more than just 3 covalent bonds. They can actually have a 4th one, right? So this histidine can act as what's called a Schiff's base, and that is spelled SCHIFF''S, Schiff's base. And I think it sounds a lot like shifts base. Maybe that's what you thought I said at first. And that is actually a really good way to remember why histidine residues can be a good buffer, because they can take on an extra hydrogen, and when they do, they shift where these double bonds are going to be made in this ring. And then they can release the hydrogen and all the bonds will shift back. Maybe if you remember a little bit of your chemistry, one of the many things, if you didn't like it, that was so annoying is how some bonds can change on you. Yeah. You're like, it was right here. This is where I left it. Who moved it? You got to turn it into something fun. Like, I specifically put the double bond here. What do you mean it wanted to go? No. So, Schiff's base. Not funny, because it wasn't funny at the time, but kind of to put things in perspective for you all, when I was in college, let me get out my cane and my walker. I selected professors because we didn't have boohoo on my professor or crap on my professor.com. I picked my professor based on how many textbooks I had to buy. Like, what was the cheapest? Didn't care. Didn't listen to the rumor mill. We really didn't even have. We didn't have cell phones back then. There was no way to chatter about, oh, don't take this, professor. Don't. Nope. So I just would go to the bookstore and go, right then, that's the one for me. And I would build my schedule around which professor had the cheapest books for the class that I needed to take. Professor Milton Sayer at UCSD, when I needed to take biochemistry, had one book, and it was no thicker than my index finger, no thicker. It's like paperback too, not heavy. All the other biochemistry instructors were using the classic biochemistry book, Stryer, and big book, very heavy book, very expensive book. So I'm like, Milton Sayer is the one for me. And this man, I really did enjoy biochemistry, but this man walked into the auditorium, big auditorium, from the top, walked down to the lectern station with his 10-speed bike on his shoulder, flip-flops, ladies, flip-flops, a torn t-shirt, usually in the shoulder somewhere, and really, really too short corduroy OP shorts. You know, Ocean Pacific brand. Some of you need to Google that. So it'd be flip-flop all the way down. Total beach dude. Smart. So his book was very useful, but all those other missing pages, that Stryer book had, we had to create them. He made us do a flip book. Do you know what a flip book is? How they originally started doing cartoons, right? A flip book. We had to draw every step of the Krebs cycle, show the binding spot of the enzyme for the substrate, show the substrate binding, show the flipping of the bonds, show also the not discard, but the release of the product, flipping of the bonds again, and then keep going. The whole Krebs cycle like that. Do not ask me to do that again. After that abuse, I refuse to memorize the whole Krebs cycle. And I know for a fact your 200 professor did not make you memorize the Krebs cycle either. You're welcome. This part, however, to reinforce the reversible equation I showed you, is important to get through your head, and you should be able to talk this through forwards and backwards. Our story begins in a tissue bed where the cells are metabolically active and they are spewing out water and CO2 as a byproduct. That CO2 will diffuse from the cells where it's being generated down its concentration gradient into the plasma. That CO2 will continue to diffuse into the red blood cell. Who knew that the red blood cell also carries CO2? It does. That's something we have to talk about a lot when we get to our respiratory physiology. So the CO2 combines with water that's in the cytosol of the red blood cell, and through an enzyme, carbonic anhydrase. This enzyme facilitates the hydration of carbon dioxide into carbonic acid. that reaction would not go very quickly without the enzyme to facilitate it. That's what enzymes do. They lower the energy activation, the activation energy required to make a reaction go. Without carbonic anhydrase, I mean, I could take a Ziploc baggie and put water in it and then go zip it up and go shake, 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 shake. That does not turn the whole thing into carbonic acid. That would not really happen. So we need this enzyme. Bicarbonate or carbonic acid can dissociate into bicarb and a very strong acid, hydrogen. Okay. Oh no, says the red blood cell. I've just now taken in a weak acid and I've made a very strong acid. What should I do? Red blood cell says, we got this. We have a lot of hemoglobin. And hemoglobin has a lot of histidine residues. Hemoglobin, remember, has 4 globin chains that are proteins. So the hydrogen ion binds to the histidine residues on the globin chains. Oh no, says the nervous part of the red blood cell. Now we have a base. Now our pH is going to climb. And the other part, the logical part of the red blood cell says, don't worry. We got this. We'll just push bicarbonate, exchange it into the plasma. We'll keep it there. Oh no, says the panic part of the red blood cell. We've just lost an anion, a negative charge. We got to balance our charges to some extent. And the logical part says, don't worry, we'll shift a different negative charge in. So this is called the chloride shift. Let's do it again without the oh no's. CO2 produced as a byproduct by metabolically active cells. Diffuses into the plasma. Continues to diffuse into the red blood cell. Because the red blood cell has an enzyme called carbonic anhydrase, the CO2 is hydrated and is turned into carbonic acid. This will dissociate into hydrogen ions and bicarbonate. The hydrogen ion will be buffered by the histidine residues of the globin chains of hemoglobin. Then the bicarbonate is going to be exchanged out of the red blood cell membrane into the plasma, and a chloride will shift in. Then this has to reverse, because remember, we started in a tissue bed. Cells are making this CO2. Okay, so where will the red blood cell go after stopping at a tissue bed in a capillary? It's going to exit through a venule to a vein, to the inferior superior vena cava, to the right atrium, to the right ventricle, and onto the pulmonary circuit, where there will be gas exchange. Now reverse it. We need the bicarb to come back in, and that means chloride needs to leave. The bicarbonate will say, hey, hydrogen ion, come with me. Come with me. So the hydrogen ion says, yeah, I prefer you. This globin histidine mess, that is not the wife I married. So it binds with bicarbonate, and then you get carbonic acid again, and that dissociates into CO2 and water, and you now have CO2 moving from your plasma into your alveoli, and you blow it out. Water we can handle because that's what the kidneys are for, right? Okay, it's reversible. Where are you? Are you loading up or are you dropping off? Where are you? Are you in a tissue bed or are you in the pulmonary capillary beds? Where are you? Which way would this equation move? Buffering is a good thing, but eventually we have to get rid of these excessive acids. How do we get rid of CO2? We ventilate, of course we do. We also do have some CO2 that is eliminated in our urine. Of course it is, in different forms, and I'm going to show you that. But we also have kidneys with nephrons that can also help us with this buffering and can also lead to excretion of these excessive acids. The question is, where in the nephron does this occur? And on a molecular level, how does it happen? Thankfully, they use the cells of the kidney use the same reversible reaction that I showed you on the very first slide. And the reason why they can use that reversible reaction is because, just like the red blood cell, they have carbonic anhydrase. To facilitate the hydration of water and CO2 into carbonic acid, here's the enzyme, which can dissociate into hydrogen and bicarb. And you're seeing here a sodium hydrogen exchanger, an antiporter. Let sodium diffuse in the cell down its concentration gradient, and you can secrete a hydrogen into the filtrate. That is a secondary active transport. Something, in this case sodium, is allowed to diffuse down its gradient, and something else is pushed out of the cell against its gradient. A secondary active transport, specifically antiport, meaning they're going in different directions across the cell membrane. Le Chatelier's principle, closely on the heels, isohydric principle. Can you remember this from chemistry? If I said you could co-write the exam with me, could you tell me? Le Chatelier's principle says this. I'm going to summarize. If you have a reversible system, like our equation, it says that if one end gets very heavy, more reactants, the reaction is going to shift the other way to generate more products. And if you get more products, it's going to shift the other way. It's like a teeter-totter. If this side of the equation we get too much CO2, we're going to try and get rid of that in the form of bicarb and hydrogen. If we get too much hydrogen and bicarb, we're going to try and get rid of that by generating more CO2 and water. Let me put it in terms we understand. Homeostasis. That's all it is. Le Chatelier's principle for chemistry is our homeostasis with Claude Bernard in physiology. It is maintaining a steady state. That's what it is. You already knew it. You knew it. Maintain a steady state. Too much here, compensate over there. Too much over there, compensate over here. That's it. That's it. And I just need you to know when we're going to shift. Are we going to shift depending on how you write your equation? Will it shift to the right or the left? That's just how I wrote it. But it's reversed. You could have written it mirrored form, right? Could have. We're going to practice that today. Okay, we've established where these acids come from. We've established this reversible reaction. We know about carbonic anhydrase, an enzyme that facilitates the hydration of CO2 with water, hence hydration, into carbonic acid, which can dissociate into carbonate and hydrogen ions. Now we need to set some training rules, okay? How to solve these problems. I'm going to start real slow. We're not going to do any math at first. We're not going to be using calculators. We're going to use our brains and just predict, okay? Okay, okay. Terminology. Anything you calculate in this class for testing purposes below 7.40 is acidosis. Okay? Always. For us, testing purposes. Even though 7.37 is still normal range in a clinical setting, for us, hard line, anything below, even if it's 7.39, acidosis. For us, anything higher than 7.40 is alkalosis, even if it's just 7.41. Doesn't matter. Alkalosis, meaning the blood is too basic. I have to be strict like this for testing purposes, just so you know your hard lines and how to make your clinical diagnosis. Okay, so next thing I want you to know, now that you have acidosis and alkalosis in mind, how can we get there? How can you have acidosis? Well, I want you to think of a water faucet, your bathroom faucets, hot and cold. Okay? You turn them both on halfway. How could you make the water hotter?
By turning the hotter one a little bit more.
Okay, so going up with the heat, and the other option? Turn down the cold. Okay, you have two options, right? So let's talk about not heat and cold or hot and cold, but acid and base. For the most part, they neutralize each other. Our pH is not exactly 7.0, but it's pretty close. So let's, just for learning, pretend that our acids and our bases are equal to each other. Okay? How can we have acidosis? Watch carefully. The easy one, too much acid. That makes sense. Or too little base to neutralize it. Good? Those are the only two ways to get acidosis. Too much acid or too little base. How can you have alkalosis? Easy way, too much base. Less obvious, too little acid. See how the base is still higher? It's not neutralized by the acid. So you can have too much or too little of something. There's still a difference, isn't there? Acidosis, too much acid, too little base. Alkalosis, too much base, too little acid. You need to remember that. The patient values that you're going to be playing with today, eventually both of the acid and the base are out of normal range. And students fall into this error of assuming if the base is more out of normal range than the acid, then it must be alkalosis or acid. That's not the right thinking. Do not do that. Do not compare the numbers. It's the equation that's going to prove that to you. You also need to know your normal values. Your normal values. And we need to know what is the base and what is the acid. Going back to the equation in the Henderson-Hasselbalch equation on the first slide, our acid is CO2. And in that equation, the acid always goes in the denominator. That is a common mistake that I see students make on their lab exam. They forget the equation. They forget the orders of operation. Don't do that. This should be a good sweep of 10 points. Next, the base goes in the numerator, and that's bicarbonate, or bicarbonate, HCO3 negative. That's your base. We have got to know our normal values. Only after you know your normal values, and keep in mind, how can I have acidosis? How can I have alkalosis? What are the two ways? Can you really evaluate the ABCs of ABGs? The ABCs of determining arterial blood gases. And so many times in nursing journals, I'll read some nurse somewhere finally gets it and writes this quick little teaching, to keep up with the credits that they need, continuing ed credits, right? And I'm like, I'm glad that you finally figured it out. And good for you for thinking of something so clever that no one else had the intelligence to think of. Anyway, comes up frequently, and you'll learn all these tricks. Okay, tricks are only good if you know the foundation. If you know the foundation, then you can cut corners and feel confident. But do not cut corners when you're just learning. Nope, nope, nope. Here is our reversible reaction and our Henderson-Hasselbalch equation. Let me explain the 6.1, the pKa. That will never change for us. It will never change. We are not in chemistry. We are homeotherms. 6.1 is called the dissociation constant. Let me act it out for you. A toddler and its parent are at the park, and the toddler is starting to have moments of independence, like, might do it, and they start playing on the equipment, but then some kid, very, a little bit older, is like, hi, can you be my friend? And then the toddler's like, mommy, daddy, and they come back. And then the parent says, go on, they're nice, go play, they've got sand toys. And so the toddler is like, okay. Wait, Ma, are you still here? Are you gonna what? Yes, I'm still here. So that's how I think of hydrogen leaving bicarbonate. Mommy, are you still here? I'm still here. Okay, I want to go back. So that's what I mean by dissociation constant. How likely is hydrogen to leave and then come back? That's all it is. 6.1. Won't change for us. The 0.03 is a conversion number. Very important, because here's why. Bicarb is given in units of millimolar, or milliequivalents. Carbon dioxide is given in units of millimeters of mercury. pH does not have units. It's one of the few rare times in science where a naked number is accepted. No units, it's unitless. You cannot divide millimolars by millimeters of mercury. Those would not cancel out on their own. And that means then pH would have a unit. But this conversion factor right here turns the millimeters of mercury of CO2 into millimolar, and then you can cancel them out. You have to do that. You can't, the saying is you can't compare apples to oranges, right? Okay, so turn the orange into an apple, and then you can. That's basically what we're doing with this conversion unit. Here's how you're going to work this problem. You first do your division problem, because this entire thing is going to be in parentheses. Please Excuse my dear Aunt Sally. So we have to work everything inside first. We start with this simple division. Then we take the log. Then we add that to the 6.1. So what are the normal values? The normal values for bicarbonate are going to be, the middle of the road is 24 millimolar, but the range is 22 to 26, with the middle being 24. The normal ranges for PCO2, and the P stands for partial pressure. The normal values of that are 35 to 45 millimeters of mercury. The middle range being 40 millimeters of mercury. If I multiply my 40 by 0.03, the conversion unit, I get 1.2. If I divide 24, the middle of the road for bicarbonate, by 1.2, I get 20. I get a ratio of 20. Let me explain what that means to you and why buying alkaline water is not something you need to do. It's expensive too, nor get the machine for it. That ratio is saying you have a 20 to 1 ratio, 20 bicarb to 1 acid. That is what it's telling you. It means you have a lot of base. You do. 20 to 1. You've got bases around to handle all those acids that you're making. So why invest more money on alkaline water? Why? You like the taste? Okay, that's valid. You like to clean with it? Okay, that's valid too. Expensive for your cleaners, but okay. But do not give me the following, which I have heard, because I got to tell you, when I see someone in the grocery store handing out coupons and saying, would you like a free bottle of alkaline water? And here's a coupon so you can buy more. Why should I drink alkaline water? I asked the rep. Well, you need more base. We make a lot of acids. Okay, that's true. We do make a lot of acids. But we have 20 bases to every 1 acid. The ratio is already in our favor. Well, cancer can't grow an alkaline pH. Really? Cancer being cancer, yes it can, number 1. Number 2, we are already slightly basic. We are 7.40. So, and everyone in this room has cancer. Everyone right now has cancer. It's just a matter of, does it get out away from your immune system? Does it continue to grow? But all of us do. All of us do. Well, I heard, it diffuses faster. Really? Alkaline water diffuses faster. Well, first of all, you're talking about osmosis, a type of movement of water. And water moves for only one of 2 reasons, either a push or a pull. Not did I ever tell you because of pH? Nope, I did not. They don't like me. They don't like me at all. So then if I take the log of this and I also take our pKa, it comes out, isn't this beautiful, to 7.40, our normal body pH. I think you need a break, and when we come back, we're going to apply this pH equation, but without the scary numbers, without the log, without the 6.1, just the bicarbonate in the numerator and the CO2 in the denominator. That's it. We're just going to talk about it. But you do need to know your normal values before we have that next part of our lecture. I'll see you in a bit. How about you come back at if you look at that page in your homework packet, again, around page 11, you will see that at the top of your page has the equations very similar to what I have up here for you. And we're going to go through them today. So yes, you're going to have a page of your homework packet completed if you haven't even started it yet. Don't tell me, don't tell me, don't tell me. But first, I want us to do some examples together, and then we'll tackle the homework packet for that page. I asked you during the break to write down your normal values for bicarbonate, 22 to 26 millimolar. Middle of the road is 24. For partial pressure of CO2, 35 to 45 millimeters of mercury. Middle of the road would be 40. Our normal value for us for this purpose here on out, 7.40 for pH. We know that's not true, right? We know that's not true, but for the sake of your lab exam, that is what we're holding on to. You'll appreciate that hard number in just a moment. You also need to know, how can a person have acidosis? Too much acid or too little base? How can they have alkalosis? Too much base or too little acid? Those are fundamentals. Fundamentals. Here's the next level. If your patient has a problem with acidosis, it could be from too little base, which means too little bicarb, or too much acid. That's what I just said, too much CO2. If it is ever the CO2 that is at fault for causing the problem, we say it's respiratory acidosis. We can have acidosis from too little base. If the base is the problem, then it is metabolic. Metabolic, a lot of students think, oh, it's just kidneys then. No, it's not just kidneys. We're not going to entertain kidney failure. You're going to get it once we practice over and over and over again. So if CO2 is the problem, it's a respiratory issue. If bicarb is the problem, then it is a metabolic problem. All right? All right? All right. So that was another layer. So in the next 4 slides, you are to identify the problem just based on me telling you arrows. Something's too high, something's too low. Where's the compensation? We're going to start out real slow. If it's a respiratory disorder, the lungs cannot compensate. I'll remind you from earlier in the lecture, lungs can get rid of CO2. Kidneys can get rid of bases and also acids. If the lungs are dysfunctional, you cannot expect them to compensate for their own problem. They're dysfunctional. If it's a respiratory issue, only the kidneys can compensate. If it's a metabolic issue, both the respiratory system and kidneys can compensate. Okay? Try on your own before we move forward. 4 slides, try and identify, is it metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. There's one of each. That's why it's 4 slides. And just tell me which organ system could compensate, could help to correct the problem. Then we'll go into details. Ready, set, go. Okay, what did you get for this first problem? Again, no calculators. What condition is it? Is it, let's start, alkalosis or acidosis? How do you know? The pH is low. Okay, now what kind of acidosis? How do you know? Say the words. I can have acidosis from too much acid, which would be CO2, or too little base. Both are elevated. Only one fits the diagnosis. Only one. And that means CO2 is the problem. So this is respiratory acidosis, and the only compensation can come from the kidneys, and what they're going to do is reabsorb all of the filtered bicarbonate, and they can also make new bicarbonate. They're going to do it from both ends. Keep what we already have and make more to neutralize. Okay? Ray's thinking about it. What about number 2? How do you know it's alkalosis? High pH. I mean, start with the basics. That doesn't fail you. Talk yourself through it. You'll get faster, but make yourself say the words in your head. Alkalosis. How can we have alkalosis? 2 options. Too much base, too little acid. Okay, both values are too low. One only fits for this. How can you have alkalosis?
Too little acid.
Too little acid. That's the CO2 part. So it's respiratory alkalosis. And we're seeing the fact that bicarbonate is low is that the kidneys are now compensating by excreting more bicarbonate. They're not reabsorbing as much. And bicarbonate, just for the record, is freely filtered. So if it's freely filtered, then just don't take what you have back in. Let it go to the toilet. That's compensation. Okay, what about the third one?
Acidosis.
How do you know? Okay, how can I have acidosis? That's the next one.
Too much acid or too little base.
Okay, what do the patient values tell you? We don't even need normal numbers, do we? I just have arrows. Okay,
So, yeah.
so it's what?
Too little base.
Too little base. Okay, so too little base. And then if it's base, it's a metabolic issue. You can't have acidosis from too little CO2. You can't. That's the acid. You can't have acidosis from not having enough acid. If bicarbonate is the problem, it's metabolic in nature. The patient has ingested something. They are throwing up, there are a myriad of reasons why. If it is a metabolic issue, what systems can compensate? Respiratory can compensate by hyperventilation, increased rate and depth of breathing. The lungs don't do that on their own. The brain tells the diaphragm to contract more. And so you blow off more CO2. That explains why the CO2 levels are going down in this patient. You probably would expect them to be doing this type of breathing. And that is oftentimes what we see in diabetics that don't have their diabetes under control. It's called Gosmal breathing. The other part is renal compensation. Don't excrete as much bicarbonate. It's acidosis. Do excrete more bicarbonate. Lost my place here in my slides. Don't reabsorb as much. So this would be metabolic acidosis. What is this problem? It is alkalosis. How do you know? pH is higher than 7.40. Make yourself say that. It's a safety net. How can we have alkalosis? Make yourself say it. Too much base, too little acid. Okay, well, everything is too much. Can't have alkalosis from too much acid. You can't. It doesn't make sense. The one that fits is the bicarb. It's too high, right? So the other one that is also out of normal range reflects compensation. How can the respiratory system compensate? Hypoventilation. Then you're trapping CO2, and CO2 levels in the blood would go up. The other way that we can compensate, because it is metabolic, is that the kidneys are going to excrete more bicarbonate. Increase. So yes, the kidneys are going to try, this is not reflecting bicarbonate compensation yet. This is at stage 0. But with time, the kidneys will compensate by getting rid of more bicarbonate. They will not make new. And that brings me to another point. The respiratory system is quick to fix. Kidneys will take longer. So if you're not really seeing, and you will in the lab, if you're not really seeing a quick adjustment, compensation, it's usually because the kidneys take about a day or so to compensate. Just to highlight, how can the kidneys compensate? They can compensate in 2 places. Either the proximal convoluted tubule or the late distal convoluted tubule with the alpha intercalated cells. In the PCT, the only choices are reabsorb all of the filtered bicarbonate, reabsorb some of the filtered bicarbonate, or reabsorb none and let it all go to the toilet. What condition would your patient be in for those scenarios? If I'm reabsorbing all of the bicarbonate, my patient must be in acidosis. If I'm not reabsorbing any of the filtered bicarbonate, my patient must be in alkalosis. Get rid of the base. With the late distal convoluted tubule, the alpha intercalated cells have this option. Should I make new bicarbonate or should I not? And you should know that this enzyme, the carbonic anhydrase, it is sensitive to pH. That's something you're going to learn again in the next unit. Digestive enzymes. Any enzyme in your body has an optimal pH. So, if your pH is too high, it can disrupt enzyme activity. If it's too low, it can disrupt enzyme activity. For the sake of the alpha intercalated cells at the late distal convoluted tubule, if you have a high pH, they should not be making more bicarbonate. That would not help you. The higher pH actually shuts down the activity level of the carbonic anhydrase enzyme. If, however, you are in acidosis, a lower pH instigates more activity in that enzyme, and then it would make new net gain bicarbonate. So those are the options for the kidney. You're looking at the proximal or distal convoluted tubule. And if you look at these slides, you'll notice that we still have carbonic anhydrase at both places. What should that enzymatic activity look like is your question. If I have alkalosis, I should not reabsorb the filtered bicarbonate as much. Let it go to the toilet. If I have alkalosis, I should reabsorb all of the bicarbonate and stimulate the carbonic anhydrase in the late distal convoluted tubule to make new net gain, a surplus of bicarbonate. Can anyone tell me what movie this slide is from?
Yes.
Yeah, what?
And I forget. Oh, I forgot the name. It's Will Ferrell, Danny McBride. It has it's so close. They go into this cave.
Okay, first of all, let me stop you right there. It used to be a TV show on back in our day. And it always scared, it is Land of the Lost.
Land of the Lost.
And that movie is a little creepy because the scientist does not hook up with Holly like he does in the movie. So I love showing students the hadrosaur urine bit. I'll pull that up when we're working again. But your urine pH can fluctuate very drastically. It can be very acidic or very alkaline, about 4 to 8 pH. In the morning, your urine is more acidic. And the reason is because you haven't been eating during the night. You have not been burning, you've burned through all your glucose and now you're burning fats. Arguably a reason to not work out but sleep more. Because then you're burning fat and you wake up and you have stinky breath. That's called halitosis, right? Come on, you've got morning breath. Yeah, that's the acetone coming out of your body. It is volatile, which means we can get it out of our body through our breath. The other two, beta hydroxybutyrate and acetoacetic acid, are keto acids. They are not volatile. We must excrete them. How do the lungs compensate? And by the way, the lungs are not muscular structures. They cannot inflate and deflate on their own. So when you tell me about compensation, I want to read respiratory system, because it is a system, not the lungs. On my slides I say the lungs can come, it's the whole system. If you have too much CO2 and it's a metabolic issue, you will hyperventilate. That means the medulla oblongata sends action potentials through the phrenic nerve, stimulates the diaphragm, it contracts, and then it relaxes after the action potential. You are inhaling more volume and more quickly. Small breathing. If it is a metabolic alkalosis problem, respiratory rate and rhythm will be smaller and less. Rate will be, both of them would be less. Rate would be less and volume would also be less. So you would look like this. Not as many breaths, kind of holding your breath, trapping the CO2 in your bloodstream. When it comes to compensation, here is a chart to help you. Acidosis, alkalosis. What is the problem? Which arterial blood gas fits your diagnosis? How can we have acidosis? Too much acid? That's CO2. If that's the problem, then it's a respiratory issue. Can you have acidosis from too much base? You can't. So that's how you differentiate between, is it a respiratory or a metabolic issue? This will help you with page 11 in your homework packet. I would know, please don't memorize, I would just have an idea of how a person can get into respiratory acidosis and alkalosis. It could be a patient on a ventilator that's rate is set too high. It could be a person that is in for respiratory alkalosis, in anxiety, having a panic attack. Oh my gosh, I just saw an accident. So many people were on the freeway. You're losing a lot of CO2. How can we help that person? Do we slap them in the face and say, get over it? No. Can we give them a bag to breathe into and out? Yes. What kind of bag should it be? Should we explore that? First, probably not best to have a plastic bag, but okay. And if you are, don't put it over the patient's head. But that is what we call rebreathing. And when you do your PhysioX on acid base, there is actually an activity where you're going to instigate rebreathing. So if the person is hyperventilating, loss of CO2, loss of acid, that means pH is going up, have them start rebreathing. But we don't hit them. You will lose your license. For respiratory acidosis, maybe the person has a restrictive or obstructive disorder, more on that to come, but they also might have been exposed to toxins that block nicotinic acetylcholine receptors, like curare, maybe. That blocks it. If the diaphragm cannot contract, how do you ventilate? If you're not ventilating, you cannot get air into your lungs. The diaphragm, when it is relaxed, assumes a superior position, and that's when air comes out. And I told you Monday that this means that it is, according to Boyle's law, if you have a smaller volume, you have higher pressure and the air comes out. What about metabolic issues? Metabolic acidosis. What is the person consuming? Aspirin is an acid. Alcohol or any other type of acid can also induce metabolic acidosis. Anything that inhibits carbonic anhydrase inhibitors, you can't convert CO2 and water into carbonic acid. So if that blocks it, then you're not going to be able to have that dissociate into hydrogen and bicarb, which means CO2 levels are basically going to be an issue. Don't think respiratory at this point. You took something. Anytime the patient takes something, that's going to be a metabolic issue. If they ingest it, if they have diarrhea, if they vomit, anything that comes in or out these two holes, it's a metabolic issue. Diarrhea, you have a lot of diarrhea, that's a whole bunch of bicarbonate buffer that's being lost from the pancreas. If you lose your base, okay, so if you lose your base, the acid still might be okay, but how can you have acidosis? Too much acid or too little base? So if you're losing your base, then the acid is the problem. Or, sorry, you're losing your base, that is the problem, and the CO2 is going to compensate. Plus the kidneys. Lactic acid, that's a byproduct of anaerobic metabolism. Patients that have uncontrolled diabetes, they start burning alternative fuels. They don't have enough glucose to actually go from glycolysis to Krebs because oxaloacetate is a rate limiting factor. And then of course starvation, same reason. We don't have enough oxaloacetate to actually feed the pyruvate into Krebs cycle. And I know that is stretching your memory, but I know for a fact your professor from 200 did tell you about this. Metabolic alkalosis, do they have leisure world syndrome? That's what we call it for elderly people that are taking a lot of antacids. That's sodium bicarbonate. They're ingesting something. Do they have potassium depletion or steroid therapy, like they're taking too much aldosterone? Here's a good rule of thumb. If the patient has hypokalemia, look for the alkalosis, okay? They go together. If the patient has hyperkalemia, look for the acidosis. So that is, and I won't test you on that, I just want you to know that that can happen. If a potassium problem first, an acid-base problem will result. If it's an acid-base problem first, it may not necessarily lead to a potassium problem. If it is a metabolic issue, if your patient has metabolic acidosis, expect them to have hyperkalemia. If they have metabolic alkalosis, expect them to have hypokalemia. But the potassium and acid-base issues are not necessarily linked when it comes to respiratory issues. Antacids, vomiting, you're losing too much hydrochloric acid. What remains behind? Bicarbonate, that's your base. You have excessive loss of acids because you've ingested something, etc., 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 or excessive loss of acids. And that could be suggestive of a kidney problem. Why do we care? If your patient is in acidosis, it can lead to death. That's why you care. Small pH changes have big ramifications. Why? It's based on a log system. We felt the earthquake, right? Earthquakes are based on a log system too. We thought it was a 6.0, turns out it was more closer to 5.1. Doesn't sound like it's a big difference, but that is. It's almost a factor of 10. We go from, let's just go for a walk outside until the rumbles stop, versus, okay, grab the cocktails, let's go have the cocktails outside on the porch for a while. And then if it's anything higher than that and we reach 7, it's grab a doorway. And we all know how effective that is. Rubble, rubble, doorway. Rubble, rubble, doorway. We don't see that in the aftermath, do we? Let's run for the hills. So we see weakness in our patient with acidosis. They have disorientation. They're not with it. They're not okay. On the other side, alkalosis, we see overexcitability. We see muscle spasms. So the patient will be like this. And there's a reason why. I can tell you the molecular reason why, but I want us to get ready for lab. But still, death can occur. So, right, we don't want our patients to die. And there is no partial credit for your patient dying. That being said, I really want you to try and work through some of the problems, either in the lab for acid-base balance, which is a more gentle approach, or you can start working on the oh no moment that I gave you and try your hand at explaining yourself. This chart summarizes what I saw in a nursing journal, the ABCs of ABGs. Okay, so what's step 1? A, determine the pH. Is it too high? Alkalosis. Is it too low? Acidosis. Step 2. How can I have a patient with acidosis? Make yourself talk it out. Too much acid, too little base. If the acid is the problem, it's a respiratory issue. If the base is a problem, it's a metabolic issue. If it's too high, alkalosis. How can my patient have alkalosis? Too much base. If that's the case, it's metabolic. Too little acid. If that's the case, it's a respiratory issue. Step 3, again, ABCs, or the 1, 2, 3s of ABGs. Step 3, if it's respiratory, where can we find compensation? Metabolic. That means we're talking kidney. If it is metabolic, where can we find compensation? Either respiratory system or the renal system. I encourage you to work through a couple problems. I really, really, really urge you to. But if you don't want to and you think you have it and you're bored, you are free to go and have a good spring break if you want to go.
Kara,
Yes.
the on Canvas, the acid-base lab, is that what we did the practice problems? Or?
The acid-base lab would be found under Lab Unit 2, right here. Introduction to Solving Acid-Base Problems. And it does have a more gentle approach. Acid-base problems will be both on lab exam, more written detail. Lecture exam, you don't need a calculator, never on a lecture exam. Look at page 11. Look at page 11 to have the most guidance. Bye. Have a good spring break. If you're not staying. If you want to know the answers to page 11, I have them written down. Right here. Did you try it already, Martha? Good job.
Okay, model? No, puso ahora.
Christopher wants to know what the kidney plaque model is.
See the one single microscope? That plaque model to the right.
Oh, the flat thing?
Yes, that's what I mean by plaque. Bye. I need you all to push hard through spring break. Like you still have to work. I'm sorry. It's just a change of pace. It's not really a vacation. Bye. Push hard for the rest of the semester. Martha's thinking.
Do we turn this in?
Hey, we're gonna-
Oh, we can just share ourselves. Okay.
Save it for any other.
I know, girl.
You're earthy.
Thank you. Have a good spring break.
Welcome.
Drive safe.
I'm not leaving until tomorrow, but I always do.
Hey, we're gonna pick it up.
Get more snacks if you want some. Hi, Sebastian.
Martha, see you on Wednesday.
Bye.
See you on spring break. See you on Wednesday.
Thank you. Bye.
See you on Wednesday, Martha.
Bye. He's a
Me-
handful.
Did you know him before you came to this class? He's a national treasure.
Yeah. Is there a reason why they have like a little star, like an asterisk on these? or-
Because those are more complicated. Great question. Those deal with a potassium hydrogen shift, which I took off of the original PowerPoint because it's beyond the scope of this. It's more advanced. I would expect you to learn about it in a Pathophys class. So that was why I put that there, for my own mental purposes.
Okay. Thank you.
You're welcome. Are you okay?
Yeah. You just talked about this and like, it's gone.
Well, that's why we have time, right?
Yeah.
And we have Monday when we come back also to like get back in our groove.